Welcome back to Senior Healthty Care, where you will discover several recommendations for seniors. Today we provide essential suggestions for seniors that cannot be overlooked. Stronger knees after 50. VMO activation plan for painful knees. Senior wellness. Knee pain impacts numerous persons worldwide and escalates with age. Numerous individuals get a chronic condition that restricts mobility, daily activities, and overall quality of life. Muscular imbalance and deterioration in the tissues that stabilize and facilitate knee movement may result in knee discomfort, ranging from acute traumatic injuries to progressive degenerative conditions such as osteoarthritis. The vastus medialis oblique VMO has garnered attention in clinical practice and rehabilitation research due to its significant influence on patellar alignment and knee functionality. The vastus medialis oblique VMO aids in preserving knee mechanics, despite its lesser size relative to other muscles. It directs the patella down the central trochlear groove of the distal femur during knee movement. When the vastus medialis obliques VMO fails to contract owing to atrophy, pain, edema, or inadequate coordination with the quadriceps, the more robust lateral quadriceps components may displace the patella laterally. The lateral deviation impedes smooth patellar tracking, heightens friction between the patella and femoral cartilage, fosters inflammation, and may lead to patellofemoral pain syndrome, PFPS, characterized by a diffuse ache at the anterior knee that exacerbates with squatting, stair climbing, prolonged sitting, or joint loading. Individuals over 50 have heightened sensitivity to VMO concerns. Sarcopenia, osteoarthritis, diminished proprioception, and previous traumas may exacerbate VMO insufficiency. Consequently, aged individuals may experience instability, stiffness, or discomfort, which hinders movement. Decreased activity promotes further deconditioning, exacerbating strength, neuromuscular control, and symptoms. Systematic incremental treatment that reinstates neuromuscular control and equilibrates muscle strength may disrupt the cycle and improve functionality. This book elucidates the anatomy and function of the VMO, the mechanisms of dysfunction, and a structured low-impact exercise regimen designed to re-educate, activate, and fortify this essential muscle. Prior to conventional strengthening, the approach emphasizes neuromuscular retraining, resulting in improved control of everyday movements. This non-invasive regimen enhances knee stability and functionality and alleviates chronic pain in many individuals by rectifying muscular imbalances and inappropriate activation patterns. Fundamental knee biomechanics and the involvement of the vastus medialis oblique VMO. Comprehending knee biomechanics elucidates the need for VMO exercises. Despite being classified as a hinge joint, the knee's stability and functionality depend on factors beyond mere bone congruence. Ligaments, tendons, menisci, and muscles regulate joint motion and alignment. The quadriceps femoris group in the anterior thigh facilitates knee extension and patellar positioning. The quadriceps consist of 4 muscles located in the anterior front of the leg. The central rectus femoris traverses the hip and knee joints, facilitating hip flexion and knee extension. The largest vastus lateralis is located laterally. The vastus intermedius lies underneath the rectus femoris, positioned between the lateral and medial components. The vastus medialis, located on the inner thigh, has 2 components, the longitudinal longus and the oblique vastus medialis obliquus, VMO. The 4 muscles create a quadriceps tendon that encircles the patella and attaches to the tibial tubercle as the patellar ligament. The VMO is significant due to its fibers being oriented obliquely at around a 50-55 degree angle to the primary axis of pull of the quadriceps. The VMO, with its oblique fiber orientation, regulates the patella by drawing the kneecap inside during knee extension, opposing the outward force of the vastus lateralis. The VMO functions as a dynamic medial stabilizer, stabilizing the patella inside the femur's trochlear groove and facilitating flexion and extension. When the VMO acts prematurely and vigorously, it reduces shear and compressive forces on the lateral patellar facet. When it is deficient or postponed, the equilibrium tilts laterally and tracking is impaired. Additional anatomical and biomechanical factors influence VMO functionality and patellar alignment. The net lateralizing force on the patella is influenced by the Q angle, the vector from the anterior superior iliac spine to the center of the patella, and the vector from the patella to the tibial tubercle. Women and individuals with broader pelvises and bigger Q angles are more susceptible to lateral tracking. Structures such as femoral anteversion, tibial torsion foot pronation, and trochlear dysplasia, a shallow femoral groove, may elevate the workload of the vastus medialis oblique to maintain patellar alignment. Neuromuscular factors, activation time and size of hip, thigh, and lower leg muscles dictate whether anatomical tendencies result in symptomatic maltracking. Onset of VMO dysfunction. Inadequate atrophied or delayed activation of the VMO disturbs the balanced forces necessary for proper patellar tracking. This may result from many interrelated mechanisms. Common roots include arthrogenic muscular inhibition, AMI, a reflexive protective response whereby the central nervous system attenuates neural input to the muscles around an injured or pathological joint. Inhibitory afferent signals from the joint may diminish the local muscle's capacity to contract after injury surgery, joint effusion, or arthritic discomfort. The VMO is particularly vulnerable to such inhibition and may shut down, staying weak, despite the integrity of the muscle's contractile structure. AMI modifies spinal reflex excitability and cortical motor representation by influencing IA and 2 afferent signals from mechanoreceptors and nociceptors inside the joint capsule and adjacent tissues. This inhibitory cascade may persist during acute inflammation, diminishing neural desire for VMO activation. Electromyographic EMG studies often reveal delayed activation of the vastus medialis oblique VMO compared to the vastus lateralis in individuals with knee pain, corroborating clinical findings of discoordination despite acceptable gross strength assessments. Disuse atrophy resulting from inactivity, immobility, or a sedentary lifestyle leads to muscle loss, with the vastus medialis oblique VMO often deteriorating more rapidly. The VMO's reduced cross-sectional area and specific fiber orientation may render it more susceptible to early functional deterioration due to extended periods of inactivity. Biomechanical variables such as suboptimal posture, ineffective movement patterns, weakness in hip abductors or external rotators, foot pronation, or anatomical predispositions such as an elevated Q angle may lead to chronic overuse of the vastus lateralis, in comparison to the VMO, resulting in a lateral bias in patellar forces. Pain-associated alterations in gait and mobility may exacerbate VMO dysfunction by influencing muscle activation. Dysfunction of the vastus medialis oblique VMO results in lateral patellar maltracking, subpatellar cartilage, erosion against the femur, localized chondral degradation, and pain. Mechanical stimulation induces anterior knee pain, swelling, rigidity, and diminished knee functionality. Alterations in joint mechanics may expedite degenerative processes and the onset of osteoarthritis. Physical challenges are often exacerbated by psychological issues such as fear avoidance, catastrophizing, and diminished self-efficacy, which hinder activities and impede rehabilitation efforts. Effective knee rehabilitation necessitates the restoration of VMO strength and the nervous system's ability to activate it in the correct sequence owing to this cascade. Rehabilitation tenets beyond fortification. Rehabilitation of the VMO needs more than only leg extension exercises. The principles are based on contemporary neuromuscular control and motor learning methodologies. 1. Re-establishing a robust mind-to-muscle connection requires neuromuscular re-education. A weakened muscle resulting from inhibition or inadequate coordination needs training to activate appropriately via deliberate focused activity. 2. Rehabilitation must address the whole support system, not only the knee, since weakness or instability in other areas may impose abnormal loads on the knee. 3. Rectifying firing patterns, ensuring muscles contract in the appropriate order, and timing is as essential as enhancing strength. Patellofemoral dysfunction is marked by timing problems, particularly a delayed beginning of the vastus medialis oblique in relation to the vastus lateralis. 4. To incorporate enhanced control into everyday movements, isolated activation and strengthening must be translated into functional weight-bearing activities. Motor learning paradigms inform practice. Frequent low-intensity practice combined with focused attention and tactile visual or auditory feedback enhances precise pattern recognition in the first stages of skill acquisition. Concentrate on varied, task-oriented and challenging situations with little external input throughout the learning process to enhance retention, transfer, and automaticity. This approach mimics a therapeutic graded exercise regimen. Strengthening starts with neuromuscular re-education. Initially concentrate on low-intensity, highly specialized activities that assist the individual with identifying and engaging the VMO. Gentle palpation of the muscle during contraction enhances tactile feedback, augmenting afferent sensory information to the central nervous system and activating the appropriate fibers. When available, biofeedback equipment, mirror feedback, and visual cues may enhance muscle learning. Initial advancement is assessed by the quality and consistency of contractions rather than by force. A reliable activation pattern must be established prior to augmenting resistance and functional complexity. Due to the knee's role in a kinetic chain, rehabilitation protocols must include exercises for the gluteal hamstring and lower leg muscles. The gluteus maximus and medius specifically affect femoral rotation and pelvic stability. Knee valgus, which disrupts patellar tracking and elevates joint stress, may arise from weakened hip muscles, permitting inward femoral rotation during weight-bearing activities. Therefore, a comprehensive program must enhance and synchronize the posterior chain and hip abductors. Rectifying firing patterns necessitates the retraining of muscle activation time. The vastus medialis obliques should support the patella early in the extension phase before the quadriceps muscles generate the predominant extension torque in a healthy knee. The vastus lateralis predominates in the first pull and laterally displaces the patella in several uncomfortable or dysfunctional knees owing to delayed activation of the vastus medialis oblique VMO. Rehabilitation exercises must enhance anticipatory activation of the VMO, therefore engaging it at the onset of movement to serve as the primary stabilizer throughout the whole range of motion. Ultimately, following isolated activation and closed chain control, the individual should progressively integrate VMO engagement into functional load-bearing activities, such as squatting, lunging, stepping, and other tasks that replicate daily demands, including stair climbing, rising from a chair, or carrying groceries. The transfer to functional tasks allows the neuromuscular system to use newly acquired control in actual contexts, therefore solidifying neural adaptations and ensuring the sustainability of benefits. Pragmatic 4-phase foundational program. A pragmatic foundational program of 4 exercises adheres to principles of tissue preparation, global posterior chain activation, targeted VMO re-education, and integrated functional movement. The exercises, characterized by low impact and an emphasis on control and contraction quality rather than intensity, are particularly suitable for a wide range of individuals, including older adults with chronic knee pain. Any therapeutic exercise regimen must include technique and pain reactions. Acute or escalating pain indicates the need to cease activity and see a professional. Exercise 1. Active quadriceps. Myofascial preparation. The first exercise is active myofascial release for the quadriceps. It enhances tissue flexibility, reduces antagonist muscular tension, and improves sensory input from the central nervous system for targeted activation. Adhesions and hyper-irritable trigger points in the quadriceps and fascia may hinder movement and contraction owing to recurrent pain, inactivity, and rigidity. Active controlled foam rolling integrates mechanical pressure with voluntary muscle contraction and relaxation to improve local tissue and augment brain input to activate the area. This technique entails positioning oneself in a prone posture with a foam roller placed horizontally under the anterior leg just above the knee, while the upper body is supported by the forearms. Initially, gently flex the knee of the leg positioned on the roller, drawing the heel towards the gluteus. This engages the hamstrings while elongating the quadriceps. Simultaneously, using your forearms to delicately draw your torso forward, allowing the roller to ascend the leg to the hip, then extend the knee as you return to the initial position. Pause for 20-30 seconds on a tense or painful area, gently repeating the knee flexion extension movement while breathing deeply to alleviate discomfort. Maintain controlled rolling and engage in active knee flexion for 60-90 seconds on each leg. For a duration of 2 weeks, do this activity daily. Thereafter, reduce the frequency to 2 or 3 times per week for warm-up or maintenance purposes. Modifications and recommendations. If a foam roller exerts excessive pressure, use a softer roller or place a cloth under the thigh and gradually increase the pressure. Utilize body weight to stimulate and mobilize rather than to damage inflammatory tissue. Incorporating gentle quadricep stretching post-rolling may enhance flexibility. Utilizing a small rolling apparatus under the leg while gradually flexing and extending the knee with manual pressure is a viable alternative for those unable to assume a prone position. Task 2. Prone posterior chain activation hold. The second exercise is a prone posterior chain activation hold to isometrically activate the gluteal hamstring and lower leg musculature. This exercise enhances femoral alignment and mitigates internal rotation, which leads to knee valgus by stabilizing the body from hip to ankle. The exercise enhances overall limb control by engaging the quadriceps and ankle muscles during terminal knee extension and dorsiflexion. Assume a prone position on a stable surface with legs extended straight and the forehead resting on the hands to do the hold. Initially, intentionally contract the gluteal muscles of one leg. While sustaining glute contraction, fully extend the knee of that leg, elevating the back of the knee slightly off the floor if possible. This exercise involves terminal knee extension and targets the quadriceps muscle group. Subsequently, bend the toes towards the shin to achieve ankle dorsiflexion. Maintain relaxation in the shoulders, neck, and jaw while executing the glute squeeze knee extension and ankle dorsiflexion with maximum acceptable tension for 30 seconds. Perform 3 sets of 30-second holds on each leg alternating sides, then release and repeat. Synchronous uniform contractions condition the neuromuscular system to see the leg as an integrated entity. Modifications and advancements. When 30-second holds become facile, extend the duration to 45 to 60 seconds, or include an ankle weight for quadriceps resistance while regulating contractions. Alleviate lower back discomfort by placing a cushion under the hips. Execute bilateral holds to assess trunk stability and simulate gait phase requirements as confidence increases. Exercise 3. Targeted VMO activation in a seated position. An accurate activation drill targets the VMO and instructs the nervous system to engage it during knee extension in the third exercise. Due to its emphasis on time and choice rather than coercion, it may represent the most significant VMO re-education initiative. The drill's nuance aids the individual with initiating movement from the appropriate muscle and maintaining it throughout ankle and knee positions by palpating the VMO during contraction and performing moderate controlled movements. Position yourself on the floor or bed with the target leg extended straight forward and the opposite leg comfortably bent to do the exercise. A little towel positioned behind the straight leg knee may provide support. Position the fingers on the teardrop-shaped vastus medialis oblique VMO located on the inner thigh just above the patella. The essential aspect of the workout is to gradually contract this muscle, ensuring it tightens under your fingers prior to moving the leg. Maintain the VMO contraction while gradually extending the knee. At full extension, extend the toes away from you, plantar flexion, and maintain for 10 seconds. While engaging the VMO, then flex the toes towards you, dorsiflexion, and sustain for an additional 10 seconds. Gradually return each leg to the initial position and repeat 3 to 5 times. The quality of contraction and the duration of consistent activation are crucial. A limited number of deliberate repeats is superior to excessive volume. If the VMO is difficult to palpate, contract the muscle while gently pressing a small ball between the knees to stimulate adductor co-contraction, which often activates the VMO. Observe subtle changes in muscle morphology in a mirror. When activation proves challenging despite consistent practice, biofeedback devices or individualized supervised physical therapy may be beneficial. Certain clinicians use brief VMO electrical stimulation and deliberate strategies to restore cortical representation and awareness. Exercise 4. VMO-focused controlled split stance lunge. The fourth exercise employs VMO activation during weight-bearing lunges. This movement associates solitary activation with routine activities such as ambulation, stair navigation, and rising following preparatory exercises. The lunge evaluates balance, strength, and motor control simultaneously. By actively activating the front limb's vastus medialis oblique, the patella is stabilized under stress, and maladaptive behaviors are substituted with safer, more efficient alternatives. Assume a split stance with one foot positioned forward and the other positioned backward at an appropriate distance to facilitate a lunge focused on the vastus medialis oblique VMO. Ensure tactile input by positioning one hand on the anterior leg VMO. Activate the front foot arch by pressing the ball of the foot into the ground prior to initiating the movement to stabilize the leg's kinetic chain. Engage the front leg's VMO until it feels firm on your palm, then press through the front foot to elevate towards near full standing, allowing the front leg to initiate the movement. Maintain the superior position for 5 seconds, ensuring equilibrium and VMO contraction. Maintain the knee in alignment with the second toe, avoiding any collapse. Return to the initial posture and repeat 4 to 6 times for each leg. The depth of the lunge should be limited by proper form and pain. Control is paramount. Upon achieving stability in control, augment repetitions, reduce pace, or include light resistance, such as dumbbells. Execute the exercise next to a robust surface for stability support. Pause before engaging the VMO at the commencement of each ascending phase to emphasize VMO timing. Alter step length and orientation forward, backward, or lateral to simulate diverse functional requirements for enhanced specificity. Supplementary exercises and advancements. Upon establishing these fundamental exercises, additional movements may be used to enhance the program. The supplementary workouts consist of isometric holds, open kinetic chain exercises, closed kinetic chain activities, and balance proprioception drills. Each category serves a specific purpose and may be incrementally included based on tolerance and functional goals. Isometric exercises. In initial rehabilitation, isometric exercises enhance strength without joint movement, which might exacerbate symptoms. Classic quad sets need sitting with the leg extended and a towel positioned under the knee. Engage the quadriceps, emphasizing the VMO for 5 to 10 seconds prior to relaxing. Perform 10 repetitions 2 to 3 times each day. Wall sits need descending until the knees are flexed at 45-60 degrees, but avoid a full 90-degree bend initially. Maintain the knees above the ankles and compress a small ball or yoga block between them to engage the vastus medialis oblique and adductor muscles for 30 to 60 seconds as tolerated. Open kinetic chain exercises. When pain allows open kinetic chain OKC exercises, separate quadriceps activity by enabling foot movement. Recline on your back with a foam roller or cushions positioned under your knee to provide a 30-degree flexion for short arc quadriceps exercises. Gradually extend the leg against gravitational resistance, with focused VMO contraction. Maintain for 3.5 seconds, then lower gently. 2 to 3 sets of 10 to 15 repetitions. Straight leg raises with external rotation include supine positioning with one knee flexed, and the opposite leg extended, gently externally rotating the extended leg at the hip to engage the VMO, elevating it about 12 inches, while maintaining knee extension, pausing momentarily, and then descending. Repeat 10, 15 times. Closed kinetic chain exercises, CKC exercises, are both weight-bearing and functional in nature. Terminal knee extensions, TKEs, using a resistance band, include anchoring one end of the band and positioning the other end behind the knee, stepping back until the band is taut, maintaining a flat foot, and engaging the quadriceps to extend the knee with a focus on the VMO contraction for 15 to 20 repetitions. Step-ups include positioning oneself before a low step, placing one foot onto it, engaging the heel to raise the body, bringing the trailing foot to align with the leading foot, and descending softly and with control for 10 to 12 repetitions per leg. Step-downs highlight eccentric control position, one foot on a low step. Gradually lower the heel of the opposite foot to the ground while preserving knee alignment, lightly touch the floor, and return to the initial position. Descents need eccentric control. Do 8 to 10 slow repetitions for each leg. Exercises for proprioception and balance. Balance and proprioception exercises enhance dynamic stability and joint alignment, hence reducing the chance of injury. The single-leg stance exercise involves maintaining balance on one leg for 30 to 60 seconds with a modest knee flexion and engaged arch. Shutting the eyes or standing on a foam pad or cushion increases difficulty. Clock taps necessitate balancing on one leg while extending the other to tap certain locations around an imaginary clock face, e.g. 12 o'clock, 3 o'clock, and 6 o'clock, consistently returning to a neutral position to emphasize dynamic stability. As strength and control improve, attempt single-leg squats, minor hops, or regulated lateral lunges. Integration of daily activities and sports responsibilities. The objective of rehabilitation is to restore enduring task-specific control applicable in real-life situations rather than only isolated contractions. Once foundational control is established, intentionally integrate VMO emphasis into routine activities. While ascending stairs, exert force through the forefoot and sense the engagement of the front knees VMO. When standing from a chair, apply pressure through the feet and activate the anterior thigh and glutes to synchronize the motion. Transform these concepts into sport-specific training regimens for athletes and physically active individuals. Regulated cutting maneuvers, incremental reintroduction to running with proper hip and knee alignment, and progressive plyometric exercises, emphasizing soft landings and knee stability. Sample progression during 8 to 12 weeks. An attainable timetable establishes expectations. A conservative approach to managing recurrent anterior knee discomfort may be structured as follows. Weeks 1-2 foam rolling targeted VMO exercises and isometric posterior chain training. Brief exercises daily or on alternate days. 5-10 focused activation drill repetitions. Assess pain and volume. Commence OKC short arc quadriceps exercises. Quadriceps sets and gentle terminal knee extensions during weeks 3 to 4. Incorporate subtle equilibrium exercises, single leg stance, clock tapping. Commence with low-height step-ups and prolong posterior chain holds. Engage in daily activation exercises and do formal workouts 3 to 4 times a week. Weeks 5 to 8. Incorporate step-ups, step-downs, progressive lunges, wall sits, and more challenging balance exercises. Enhance gluteal and hamstring strength with side-lying clams, hip lifts, and resistance side steps. Incorporate functional task training, e.g., rising from low chairs, ascending stairs. 3 weekly workouts supplemented with activation exercises on alternate days. Weeks 9 to 12 plus multi-directional lunges, regulated plyometrics, incremental running, and athletic cutting drills. Conduct weekly maintenance activation drills and assess higher impact operational capacity. Diversity in individuals is expected, and clinical judgment ought to direct development. The pain response, fatigue, and functional goals should dictate dosage parameters such as sets, repetitions, duration of holds, and frequency. To effectively measure tolerance, increment one parameter at a time, such as repetitions prior to resistance. Assess progress and anticipated outcomes. Progress may be assessed both subjectively and objectively. Pain scores functional assessments, such as the ability to ascend stairs, do household tasks, or traverse long distances, and activity confidence are subjective measures. Validated patient-reported outcome assessments, such as the Kujala Anterior Knee Pain Scale (AKPS) and the Western Ontario and McMaster Universities Osteoarthritis Index (WOMAC), can quantify temporal changes and inform treatment decisions. Objective assessments include strength testing using portable dynamometry, if appropriate timed single-leg stance, the number of controlled step-ups, or lunges performed without pain and knee alignment during activities. A film of single-leg squats or step-downs may assess dynamic valgus angles and demonstrate improvements in movement quality. EMG testing in specialized circumstances may objectively reveal variations in VMO vastus lateralis activation times. However, it is not essential for standard therapeutic therapy. With dedicated practice, VMO activation may enhance within weeks. However, functional gains sometimes need months. Enhanced neurophysiological timing and recruitment patterns often precede hypertrophic strength gains. Patients often experience pain alleviation and enhanced confidence in daily tasks within 6 to 12 weeks. However, a sustainable return to high-demand activities requires 3 to 6 months of progressive training. Safety contraindications and cautions. Safety and professional guidance are essential components of any recovery process. The outlined exercises are low impact and generally safe for the majority. However, if you have considerable edema, instability, ligament or meniscal injuries, uncontrolled systemic conditions, or have had recent surgery, please seek advice from a physician or physical therapist prior to commencement. A physician can precisely diagnose, exclude structural problems requiring other treatment, and tailor the program to the individual's limitations and goals. Engage in exercise devoid of acute piercing or escalating pain. Muscle fatigue, temporary soreness, or mild discomfort are typical as tissues acclimate. Nevertheless, intense pain during or after exercise serves as a cautionary signal to cease and reassess. In joint rehabilitation, prioritizing cautious progression with an emphasis on technique and consistency yields safer and more sustainable results rather than adhering to the mantra, "no pain, no gain." In the event of abrupt swelling, joint locking instability, or escalating pain, get medical assistance. True locking, severe instability, or signs of infection, fever, acute localized erythema need prompt medical intervention. Changes for common comorbidities and demographics. In osteoarthritis, emphasize joint loading and low-impact pain-adjusted progress. Aquatic therapy is ideal for early strengthening and gait training because water buoyancy reduces joint stress and facilitates resistance and neuromuscular exercises. Initial CKC, isometric, and low-range workouts are popular. Obesity, lower step elevations, longer recovery, and slow progression. Focus on motor control and alignment for safe biomechanics before adding loudness. Think about supervised sessions. Weight management should support therapy. After arthroscopy or TKA, follow surgeon and rehabilitation instructions. TKEs, soft quad sets, and passive ROM are begun early under expert supervision to activate the quadriceps and VMO, although time is important for healing. The pace of recovery depends on edema and wound healing. Manual assistance and continuous progress may improve vestibular balance exercises. Starting with sitting activation exercises, move to standing as tolerance develops. Concurrent issues may need vestibular experts. Neurological conditions. Neurorehabilitation therapists must tailor remedies to neurological illness coordination and strength deficiencies. This may need slow growth encouragement and assistive technology. Additional methods. Supplements may boost exercise. Weight control, anti-inflammatory drugs, ice post-exercise, and orthotics or footwear to alleviate excessive foot pronation are adjuncts. A trained doctor may conduct soft tissue or patellar mobilizations to reduce discomfort and mobility restrictions, enabling active rehabilitation. Electrical stimulation devices may activate muscles after considerable inhibition, but usage must be tailored. McConnell tape, or temporary patellar bracing, may align the knee and reduce discomfort, improving exercise performance. This should improve active neuromuscular training. Corticosteroid injections for severe inflammatory bouts may reduce pain and increase rehabilitation, but they do not fix neuromuscular deficits. Tips for practicality and success. Consistency and care are key to success. Concrete measurements include: schedule shorter, more frequent workouts. Start with tactile or reflective stimulation to stimulate muscles. Record exercises, repetitions, and pain to track progress. Minor accomplishments motivate. Be reminded to exercise, such as doing activation exercises while watching TV or during breaks. Get expert feedback to improve technique advances and barriers. Clinical staff may safely escalate interventions. Common technical difficulties and fixes: knee collapse during squats or lunges. Engage hip abductors and external rotators with knees over toes and gently push the knees outward toward the second toe. Side-lying clams resistance band walks. Before full-range repetitions, use tactile feedback, mirror exercises, and brief focused contractions to activate VMO. Before knee-centric workouts, do prone glute squeezes, bridging, and resistance side steps. Excessive anterior trunk inclination. Tell them to elevate through the chest and use shallower ranges until control improves. Model instances. Patient 1. Elderly chronic anterior knee pain patient. Stairs and low sitting have aggravated anterior knee pain in a 62-year-old lady for 3 years. She feels stiff after sitting and swollen after gardening. Single-leg step-downs show mild medial vastus medialis atrophy, delayed activation compared to the vastus lateralis, gluteus medius, weakness, and dynamic knee valgus. After medical approval, she undertakes foam roller preparation and prone posterior chain holds for 2 weeks, precise VMO activations 3 times a day, and short arc quads and quad sets every other day from week 3. Step-ups and controlled lunges are added in week 6, and by week 10 she has increased stair tolerance, decreased pain intensity from 610 to 210, and improved single-leg control. Progressive healing, hip strengthening, and motor retraining are shown in this vignette. Case 2. Middle-aged recreational runner with PFPS, increased weekly mileage and hill repeats, have caused anterior knee discomfort in a 38-year-old recreational runner. Electromyography shows hip abductor weakness, excessive foot pronation, and delayed vastus medialis obliquus. A brief intervention involves gait adjustment to shorten strides, cushioned shoes with orthotic support to minimize pronation, and home gluteal strengthening VMO activation and progressive closed kinetic chain exercises. The patient reports decreased discomfort and better mechanics after 12 weeks of moderate volume increase, encompassing tough and light days, continuing former mileage levels. When to referral to an orthopedist, sports medicine physician, or advanced rehabilitation specialist is necessary if a patient fails to progress despite diligent program compliance or exhibits alarming symptoms such as persistent or exacerbating swelling, mechanical locking episodes of instability, or neurological impairments. If clinical reasoning suggests intra-articular disease beyond neuromuscular dysfunction, radiography or MRI may be needed to investigate structural aspects. Synopsis. The modest but important vastus medialis oblique muscle controls patella position and knee health. Impaired or blocked VMOs may cause knee discomfort and dysfunction, especially in those over 50, with age-related changes, arthritis, or past injuries. Tissue quality, the mind-muscle connection, the kinetic chain muscle contraction duration, and daily activity regulation are all part of quadriceps rehabilitation, a systematic program that develops from active tissue preparation to focused VMO activation to functional load-bearing exercises, may restore coordinated muscle function stability and knee confidence. This non-invasive movement-based technique complements invasive therapies. Human physiology states that the neuromuscular system may adapt and recover with specific stimuli and persistent practice. Reactivating and strengthening the VMO may improve mobility, knee pain, and quality of life for active people. Thank you for watching the video. Please let us know your thoughts, and goodbye for now.